Welcome everyone. My name is Kevin Sofin with WS Darling Company and smartfirefighting.com. And we host these events to help raise awareness and connect the dots on all things relevant in the fire service today. And today we're going to be exploring some of the challenges and ongoing impacts of COVID in the fire service. Granted, we all have COVID fatigue. I know it's been something that has been draining on. The vaccine is showing some proof of quote unquote normalcy. What is normalcy? We don't even know. But firefighters in the fire service have some of the biggest challenges within the job before COVID. And now COVID's making it more challenging with recruitment, retention, dealing with issues of overtime, a lot of compounding stressors. And now COVID has created a whole range of new challenges, particularly around this new concept of the long hauler effect. And this is something that I'm still learning about, we're all learning about, but I have an amazing panel here with Chief Todd LeDuc, Dr. Denise Smith, Lori Moore Merrill, and Sarah Jonke, where they all have amazing context. I don't want to butcher their intro. So what we're going to do is we're all going to do a quick little 60-second intro of who they are. And then after that, Todd's going to give an intro about laying the foundation here. Denise is going to give some context on what we know and don't know. Sarah will then provide some context around behavioral health and organizational impacts. Todd will then talk about role of baseline health evaluations and ongoing medical evaluations. And then finally, Lori is going to give some context around exposure tracking and survey results. And one thing I'll final parlay here is ask questions. This is sort of like organized pandemonium. We're all going to be talking and elaborating and just sort of jumping all over each other. So the speakers will be bouncing off each other, and I want you to use this as a chance to learn from them. So without further ado, quick intros. We'll go Todd, Denise, Lori, Sarah. So Todd, if you can give us a little quick 60-second intro to get us going.
Absolutely. Thanks, Kevin. I'm thrilled to see all the representation we have from international, actually. So thanks for joining us. Always excited when I hear it's going to be organized pandemonium. That's what we do, our best work in the fire service, as you all know. By way of introduction, my name, as you mentioned, is Todd LeDuc. I retired, blessed to retire after 30 years of service with the Broward County, Florida Fire Service as Executive Assistant Chief. I joke all the time, I failed retirement miserably. I got one day in of golf. And then went to work with a company called LifeScan Wellness Centers. And we do about 50,000 annual first responder physicals a year across the country. I'm also very, very fortunate to have served on the International Association of Fire Chiefs Safety, Health, and Survival Board. I think, I hate to say it, but for the last 16, if not 17 years. So real critical issue I think we're going to be talking about today, and I'm thrilled. I'm a little humbled to be the only doctor joining the rest of our elite group here. That I look forward to this dialogue because I think we are going to have to continue to keep our eye on this issue.
Denise.
Good morning. Thanks, Chief. Let me say how pleased I am, Kevin, that you brought us together for this important topic, and how great it is to be talking with people for whom I have such great respect. So I too am looking forward to the pandemonium that might ensue as we talk about a really important topic. I am Denise Smith. I'm a researcher at Skidmore College. I also work with the Illinois Fire Service Institute, and I've been doing some research on firefighter health and safety probably for about 25 years. With a real emphasis on cardiovascular disease risk factors, cardiovascular strain of firefighting, cardiovascular death in the fire service. And in fact, you'll hear today a little bit about my thinking, because with COVID, of course, I'm concerned with it for all of the reasons that everyone is, just, paying attention to the statistics and how devastating it's been in our communities and in the fire service. But I also see it from the perspective of the cardiovascular issues we've been facing and how it complicates those and how that partially explains some of the devastating effects. So I'm pleased to be with you. Thank you, Kevin.
Thanks, Denise. Lori.
Hello, everyone. Clearly, Denise and Todd have no concept of 60 seconds. So, so we'll keep it. That was my first over the bow shot, right?
That's a filibuster. That's called a filibuster.
Lori Moore Merrill, formerly with the IFF for 26 years, where I led the research division, leaving there a couple of years ago to stand up the new institute, International Public Safety Data Institute. So living all things data, I work with these three often now. Maybe I should say I work for them often now, and making sure that they are successful in their own research venues. So excited to be here today. And we're going to talk a little bit about exposure tracking, as Kevin said, and presumption, right? So if anybody understanding better of COVID presumption. Thanks.
1 minute and 6 seconds. Nice job. That's an A+, Lori.
Yeah, 100%, maybe like 95%. Sarah.
Hi, I'm Sarah Jenke. I'm the director of the Center for Fire Rescue and EMS Health Research. Honored to be with these folks who just always love to give each other a hard time. Do firefighter health research, everything from kind of the behavioral health to the modifiable risk factors, so fitness, nutrition, that kind of stuff. Interested in this conversation, both from like the biological impact and the just kind of the way COVID has affected the fire service. So currently have a FEMA funded AFG project on kind of how the fire service has handled this and how they're going to best move forward. And that was actually under 45 seconds.
Killed it. Awesome. Well, like as you all can see, a really, really amazing panel and group that I've grown fond of, to just enjoy listening to, and I already got a half page of notes. So and we haven't even started yet, but get your popcorn ready. This is gonna be a good time. So Todd, give us a little bit of, paint the picture here and set a little intro for what we have with everything else Denise, Lori, and Sarah are going to talk about. Paint the picture in a quick little intro about what we're going to be talking more about here.
Sure. Great intros from everyone. I got to give hats off to Sarah for coming in just shy of 50 seconds. She's been practicing. But all kidding aside, I think we're a year into, as best as we can ascertain from reporting, COVID reaching the shores of the United States and impacting our country, and obviously this is a global pandemic, so it's a larger issue. But at some point early on, when we started hearing reports of folks being infected, there were small, tiny dribbles and drabs of information of some pretty serious complications that were affecting multiple systems within the body: neurological, pulmonary, cardiovascular, and psychological as well, behaviorally. And what came into my mind immediately was the implications of even 20 years now. This will be the 20th anniversary of the 9/11 horrific attacks in the country, and we're still losing first responders from the impacts of Ground Zero and that tragedy. And in my mind, I started thinking out, might there be long-term consequences to being infected with COVID? And obviously time has passed. We're 12, 13 months in. There's been more reports that have come out from different countries, and more research that has been able to start shining some light on what has seemed to have come up with the terminology of long hauler. And I don't know how common, we understand that, and what we understand that to mean. And Denise is going to help walk us through some of the implications. But early on, I raised this issue with a lot of colleagues, and rightly so. We were in the midst of a pretty big battle, if you will, just the day-to-day operations, getting PPE, making sure we had staffing, because many of our members were infected and couldn't, we had to quarantine them. So it was, rubber meets the road. We still had to have day-to-day operations. And as we've made some progress against the vaccine, I think we've all had a chance. And I know we've all, as a group here with Denise and Sarah and Lori, and and others been able to look at this in an analytical way and start having this, raising the awareness and having the dialogue in terms of, we know a lot of first responders have been infected. We know that many of the infections were asymptomatic, and some of our first responders may or may not even be aware if they hadn't been tested for antibodies that they had been infected, and what that's going to mean longer term, both physically for them, job performance, presumption if need be, behaviorally, and what impacts we'll see, and in organizationally, how does all of that tie together as we look at these issues? So for me at least, I hope the goal for today for all of us that are listening and those that will, when we share the recorded version, will be for us all to start thinking, what do we need to do to make sure we continue to keep an eye on our people, to keep them safe for the long term, right? The goal is always to have our members serve a long and healthy career and then enjoy a long and healthy retirement in good health. So I want to, hopefully that sets the stage, Kevin, just to what we're thinking. I know with Lori's help, this group led, Denise did a wonderful job, and she's going to share that coming up. But we shared some of this with the International Association of Fire Chiefs COVID Task Force. Lori was able to get some time for us to get in front of that group, which is really a multi-faceted group. The IFF's on there, private EMS is on there, federal agencies are on there. So again, just putting this on the radar screen as the things we need to be thinking about as researchers, as chiefs, as labor leaders, and as individuals that are first responders. So I know Denise is going to help walk us through to lay out what we know, and in some cases what we don't know. So we'll be off and running.
Yep. Well said, Todd. Yeah, nothing is clear cut and dry here. I mean, there's a lot of complicated factors and everything is interconnected. And thank you for setting that stage. So without further ado, Denise, I can pull up your slides and share the screen. 1 second. Let me put that in PowerPoint mode. All right, Denise, you want to just tell me when to go? Next slide.
Oh, sure. If that's easiest, go ahead and hit a return on this, because I mean, there's so much we could talk about with COVID, but we're going to keep it just to the fire service. And even there, we're going to be rather brief. Some of this will reiterate what's already been introduced by Kevin and Chief Leduc, but the fire service has been deeply involved in COVID from the beginning, right? You were first responders on this. And I will tell this group, I'm at an academic institution. And when the executive team came to me and said, hey, we're a little bit worried about COVID, our administration was trying to think, what do we do with our students? What do we do about protecting faculty? And they asked my opinion. What I suggested is that they hire a fire chief to run this response, because you are so familiar with evaluating risk and responding to it. But to go back to this, so you've been dealing with your PPE, preventing infection since the outset. You've been instrumental in the vaccination, not only within the first responder community that's at increased risk because of your public responsibilities, but you're also helping the public become vaccinated. So I don't want to spend time on that, but I do want to acknowledge it. One is because I'm grateful for those efforts, and the other is because part of the COVID fatigue that's felt in the fire service is not just because this has been going on for over a year, but because you have carried such a heavy burden for over a year. Nonetheless, as others have mentioned, and Greg even mentioned in the chat function, complacency is not our friend now. We need to be attentive and thinking about the long-term consequences and setting up ways to mitigate those now. Could we move ahead, please, Kevin? So just real quickly, I know COVID affects every part of the fire service, from operations, financial to health. Go ahead, Kevin. It's really the health aspects that we're going to pay attention with. I say this, I know that you are far too familiar with COVID on one hand. The fire service understands this pandemic far better than the rest of the population. It's affected almost every part of what you do. And so some people are tired of hearing about it. But we have to keep in mind, go ahead, Kevin, there's a lot we don't know. And what we do know tells us we should still be paying very careful attention. So we don't know how many firefighters have been infected with the SARS-CoV-2 virus. There's some estimates that it's as much as 1/3 of the fire service. We don't know the severity of those who have been affected. We don't know what proportion has been asymptomatic, mildly sick, even all the way up to fatal outcomes. It's very hard to keep track of. Some people are trying to keep track of the fatalities that occur if COVID could be related to occupational risk. But honestly, I would say we don't have very good prevalence statistics on any of this. We know very little about the time course of recovery, whether we're talking about an individual with a mild, uncomplicated course or the long haulers, those with long COVID, or those with persistent COVID. In fact, sometimes we're not even sure of the precise definition of those terms. And there's a lot we don't know about the impact on policies. What about return to work? What about medical evaluations and findings that are new post-COVID? And what impact does that have on being cleared for duty? Or things that we need to do to perhaps rehabilitate individuals. A person who suffered from COVID may not have the same fitness level 4 or 6 weeks later. Also, disability and retirement need to be considered in this context. Kevin, could we move forward? So I want to talk a little bit about the long-term consequences of COVID. First, to share some things that are disturbing, right? It is disturbing to know that the medical community is putting out articles at a pace that is just unimaginable, even for researchers to keep up with this. So I know full well the fire service isn't reading the 1,800 articles that are coming out every month now on COVID. But clearly we're seeing data that suggests up to 1 in 4, 25% of individuals have symptoms 4 weeks after COVID. That's not in the fire service, that's in the general population. And 1 in 10 have symptoms that last more than 12 weeks, meaning they might be defined as a long hauler or someone suffering from COVID. If we were to extrapolate these numbers to the fire service, it would suggest that there's a tremendous impact. If someone's not ready to return to work for 4 weeks, that's significant. If they're not ready to return to work after 10 weeks or more, that can be very, very concerning. And here's new data out within the last month showing that in patients who had a mild course of the disease, so I'm not talking about the sickest, which we sort of intuitively thought that the sickest people would have the longest time course for recovery. But new data is showing that even in patients who had a very mild course of the disease, 30%, 1 in 3 had symptoms 6 to 9 months later. Go ahead, Kevin. So when we say they have symptoms, what are the symptoms we're talking about? And if I could just apologize, I am going to do a little bit of science and medical science now so that we all get on the same page, because one of the things that has us underappreciating the severity of COVID is that the symptoms are so broad, such a range of presentations, that we're sometimes failing to link them back to COVID. So the broad range of symptoms often overlapping. It can be chest pain, muscle pain, fatigue, shortness of breath, cognitive dysfunction, that can be the brain fog, it can be altered mood states, anxiety and depression, and also the headaches can be associated with this for long term. Now, this is where medical research is doing so much. We don't actually understand the mechanisms fully. We're getting new insights into that. But one question is, how can this virus be creating such a broad range of symptoms? And I'm going to try to present something that's a little bit cohesive for us to consider. Often the mechanisms include inflammation. You've undoubtedly heard of that, right? The cytokine storm, the inflammation with COVID, the increased propensity for blood clots or thrombosis. I'll talk about that a lot because that's related to some of the fatal events that we're seeing, as well as serious complications. And then autoimmunity. Now, autoimmunity often involves inflammation or an overactivation of the immune system, and that can lead to thrombosis or increased blood clotting. And so these three are not separate mechanisms, but they're also overlapping. Next slide. Forgive me, I know this is a busy slide and it's against every rule for building a slide, but I want to get this out there because we all need to be attentive to these things and looking for potential connections to COVID. The increased clotting or thrombosis, that can be leading to strokes, heart attacks, and pulmonary embolism. When you hear those three things now, they've been with the fire service all along. But let me take pulmonary embolism. People with COVID are let me say it differently. 1/3 of the people with COVID had complications around blood clotting, whereas critically ill people, that's usually 1%. So if we're hearing about blood clotting and pulmonary embolism in this environment, we want to ask the question about COVID. Hypertension and related disorders. Hypertension has been with us for a long time. It's elevated in the general population to a point that's unhealthy. The fire service has its own concerns, but there's new onset of hypertension related to COVID. And hypertension leads to other problems, aneurysms or valvular problems. Think COVID. The pulmonary congestion, shortness of breath, coughing, you know this well, but it's particularly problematic for firefighters because of the strenuous nature of their work. Cardiac damage. The cardiac damage is often a result of inflammation, but that can actually lead to fibrosis. So you have an increased risk of both arrhythmia and clotting. The excessive immune response, we've talked about its long-term inflammation. The metabolic syndromes, this can be newly diagnosed diabetes or insulin resistance. And the neurological disorders, sometimes we refer to that as brain fog. Many people do report the short and long-term memory loss. Thank you, Brian. It can also be changes in mood state. And I think Dr. Janke will talk to us more about that. Kevin? Folks, I'm going to finish up with a couple of slides talking about the vascular endothelium, the vascular endothelium. And I want to talk to you about, like, what is it, where is it, and what does it do? But I also want to signal to you the reason I want to do this is because this explains many of the symptoms. It's much of the mechanistic reason that COVID can affect so many systems of the body. So the endothelium, shown on the left-hand side of my screen, the endothelium is the lining of a blood vessel. So everywhere you have blood vessels, in the brain and the heart and the muscles and the spleen and the kidneys, everywhere you have blood vessels, you have endothelium. So the endothelium is what separates your blood from the tissue underlying blood tissue. So the endothelium is a semi-permeable barrier that allows some things in and not. And if that permeability changes, you can get things like congestion in the lungs. It regulates vascular tone. Can you increase blood flow to the heart if you're doing firefighting activity and you need more blood supply? It also regulates the immune response, inflammation and cytokines. The endothelium actually releases many of these and it responds to them. And it responds by making the endothelium more procoagulatory. Next slide. So, Kevin, what I want to show here is, like, here's a question: why do we care, right? I know I'm talking to the fire service, but I want you to care about the vascular endothelium because it helps explain the broad range of symptoms in COVID, and because it has specifically been shown to be affected by firefighting. So firefighting causes the blood to become more coagulable anyway because of changes in the endothelium. And so for firefighters, we have to be asking the question and attentive to, are firefighters more at risk post-COVID because it intersects with changes that already occur with firefighting? So there's a real question, and we don't know this yet, but what are the acute effects of COVID on the acute effects of firefighting? Right? That's a real question. If we knew before firefighting changed platelets, increased coagulability, is a person who had COVID more likely to have an extreme response when they catch a bad fire and they have to go all out? And then chronically, there are other occupational stressors that affect the endothelium. Smoke and particulate matter has terrible effects on the endothelium. Now you have some policies in place with respiratory protection, and I'd urge you to be, even more diligent about protecting the respiratory pathways. But once this comes into the body, it affects the endothelium terribly. Kevin, and so let me finish with the pathology here and try to let you see some things you already knew and put it together on this picture. So the SARS-CoV virus, the virus actually binds to ACE2 receptors. You've heard that term, the ACE2 receptors in the lungs. We first thought of COVID as a respiratory disease because of the symptoms of acute pneumonia, et cetera. But then we understood also it enters the system through the respiratory system. But remember, the respiratory system is richly supplied with blood vessels, right? That's how we get, oxygen into the blood. And all of the endothelium is also has these ACE2 receptors all over it. So the CoV-2 virus binds to ACE2 receptors, and that's how it gets into the body. And from there, you see in the yellow endothelial dysfunction. And I've highlighted for you that the endothelium releases cytokines, and the cytokines damage the endothelium. This is what we call a positive feedback loop, and that's why it gets to be called the cytokine storm. It gets out of proportion because it's a positive feedback loop. And then the endothelium can lead to damage in the heart, the myocarditis and infection. It can cause blood clotting. It can make the heart more susceptible to an arrhythmia. It can promote heart failure in an individual with problems, lead to deep vein thrombosis, pulmonary embolism, cause damage to the kidneys. And again, I just want to say I've been focusing on the cardiovascular complications and how the cardiovascular can relate to all the systems of the body. Not shown on this figure is also the brain. The brain is richly supplied with blood. And so many of the changes we're seeing there may be due to changes in the endothelium that's causing either inflammation or congestion. Last slide. Thank you for indulging me, just so we had some common things to talk about with the panel. But I would like to end just by saying, I don't want to just dump this on us. I want to say, what does the fire service need to do? I would say what you normally do, a 360 size up, get your head around the risk. We need to gather information on how many people are affected and how severely. We need to be attentive to the risk. And that means just thinking about all the things that might be related to COVID that we didn't initially understand. And then we need to be prepared to act to protect the health and safety of our members. Thanks for giving me so long to give that brief intro. I know Sarah will help us understand the equally important behavioral health side of this for the fire service before we get to the discussion part. Thanks all.
Thank you, Denise. That was awesome.
Yes. I don't know about everyone else, but I'm pretty depressed after hers. So I think that is a fantastic lead-in.
Yeah, depressingly eye-opening.
Yeah. Thanks for that, Denise. Someone did ask in the chat, average age of long haulers. And the latest data I saw on that, and Denise can tell me if she's seen something different, but it was a younger group. And that's one of the big concerns, is the average age was closer to like mid 40s, where people were long haulers and people who had been pretty healthy, where I think early on, everyone felt like these, it's the people who are already sick. But is that what you're seeing?
Yeah, thank you for making that point. Yes, it is really concerning that it is in relatively young people, not the group we thought was at risk, right? Young people, and mid 40s is consistent, early to mid 40s is consistent with the data I've seen. And again, it is not just the people who had severe COVID. It could be, they're not off the hook, but it's people who thought they had a mild course of it. And then they go on to see, no, 4 months later, they're having these terrible muscle weakness, pain, and fatigue, or shortness of breath on exertion.
Yeah. Before we can move on to Todd, Lori, any thoughts, comments, questions in regards to what Denise was just saying?
I think that, like Sarah says, it's a little bit depressing, but I think it is something that we have got to make people aware of, because if the chiefs are seeing this, or if you've got people calling in sick because they're having, COVID type symptoms, and now it's just the flu because it's only one day, or if you are observing people on a fire ground that all of a sudden they're sucking down a bottle of air, or they're coming out because of the fatigue factor, right? So we've got to be observant. So that's what I would say, is that we really need a heightened awareness of the possibilities. It's not that it is going to be widespread, it's that it could be widespread, and we need to be aware and call it what it is if we see it. And so I think right now we've got a real education hurdle in front of us, just to make people aware. I'm still talking to people that are saying, well, I've never even heard the term long hauler, right? Even though it's now getting in the news and it's starting to roll out. So we need to stay really diligent about alerting people.
Thanks, Lori. All right, Todd, do you want to set the stage a little bit on some of the importance of the baseline medical test and ongoing medical evals, and then after that we'll go to Sarah and then Lori, and again continue to
absolutely, Kevin, and like I think all my colleagues have said, the little that we know is very sobering. I'm reading here in some of the comments, a 23-year-old who contracted, actually suffered multiple heart attacks and ultimately had a cardiac arrest. Denise laid out multiple systems that are potentially impacted, and some may be more subtle presentations than others. But one of the things that I think we need to be mindful of, and I think we saw this, and maybe Lori and or Denise can touch on, post 9/11 medical surveillance, and what we went through to support those first responders that had occupational impacts from being at ground zero. What I look at when I think of being able to provide the most support to our members is, do we have the processes in place to look after their basic health changes? So many of the things that we've talked about that can be potentially from long hauler effects, whether that's physical or behavioral, we need to have a baseline physical in place to be able to say, here's kind of the baseline status, even if that was immediately, post-exposure, a year post-exposure. Hopefully, we have many years of physicals, but, I go back to some of the work the IFC did in 2016, where we surveyed the chiefs that are members of the International Association of Fire Chiefs. And at that point in 2016, 20% of career departments had no physicals in place for their members. The number was almost double that for volunteers. So 40% of volunteer departments did not have occupational physicals in place. And I think when you looked at, Sarah's going to, I think, touch on some of the potential behavioral impacts that we've seen and likely may continue to see from COVID. Only 10% of departments had any type of behavioral health screening in place nationally. So I think, and I'm kind of a little bit biased because of my new role in working for LifeScan and seeing 50,000, almost 50,000 first responders this year. Those are departments that have an excellent baseline NFPA baseline status. But I think departments, both individuals and leadership in the department. And when I say leadership, at the chief level, at the labor level, volunteer leadership, we need to be very mindful, as Lori said, and I think we're all trying to say, is increasing the awareness that these are potential things that we're going to be seeing coming down the pike for our members. And at the same time, make sure that we have, I know Lori's going to touch on presumption and the issue of presumption and how it may or may not apply. But certainly when you're talking about presumption, having that baseline physical and also being able to find subtle changes. I mean, some of the things Denise talked about, inflammation processes, cardiovascular changes actually to the structure of the myocardium, inflammatory markers in the blood, are things that unless we're getting a specific firefighter occupational physical, we're likely to miss many of these subtle signs. And tragically, unfortunately, in our business, as we all know, that when we miss early warning signs, bad things, tragic consequences often happen. And Denise has done so much work on just the cardiovascular stresses and extremes of firefighting and the changes that occur separate from having COVID. But now when we add the complications that we're seeing and likely to continue to see of COVID exposure, having those baseline occupational physicals are a huge tipping point for early identification, even if it's very subtle changes. And we know the quicker we can identify whatever the process is, the quicker we can get our medical folks to intervene with treatment options. And we know the outcomes are better. For those of you on the line that are cost administrators, we know the costs are better the sooner we find things. So I just want to, I know as we continue to talk about all the different facets of how this may impact organizations, really want to put out there the importance of having that medical surveillance program in place. And ultimately that may become a more of a federal discussion as well as we look at, appropriating dollars. I know there's already been a lot of money put aside for researching the long hauler effect, I believe with NIH. But we'll continue to need to gather data. And the only way we're going to be able to do that is to have good mechanisms in place to find that information and find it early. So just something to be mindful of. I know we've done these webinars before, and people have heard me say this and probably tired of me saying it, but I'm going to continue to say it. Where we ask, how many people have an apparatus maintenance program in place? And Kevin, I think you asked, you've got one of those survey tools that you do, and almost every webinar when we ask that, 100% of the people on the webinar raise their hand and say, of course, we would never get into a vehicle, an apparatus with faulty brakes or bad tires. But we need to do now more than ever, I believe, as good a job with medical surveillance of our members. So I think hopefully that's a good segue to, Denise laid out a lot of the physical impacts. We start looking even at some of the behavioral health impacts. It's even more compelling, I believe.
Thanks, Todd. Well said. And from Sarah and Lori, again, want to spur this random pandemonium. So I want to throw it over to Sarah to really dive into behavioral health and organizational impacts, and then allow us all to continue to interject. But again, if you are in the audience, keep firing questions. This is your chance and your opportunity to get an answer from this crew. So Sarah, floor is yours.
Yeah, so behavioral health impacts of COVID and COVID long are kind of like twofold what we're seeing. So on one hand, there's the fire service response and just the stress of being a frontline worker, like the uncertainty of the whole situation. And then at this point, like we did another webinar that was just like, will this ever end? Like it's the impact of, for everyone in the country of this being such a stressful experience, but especially for the fire departments and all the uncertainty that came early on, all the kind of changing response that happened. You know, a lot of people talked about how frustrated they were with departments saying one thing one day and then 2 days later saying the opposite, which unfortunately was kind of like the evolution of the science behind COVID. So I think there's definitely that impact. And then there's also, Denise did a great job describing some of the stress on the system and the endothelial dysfunction. And it does look like there is an impact with that in terms of behavioral health. So there was a really cool study where they looked at, I mean, I think all studies are really cool, but this one was particularly cool because it had looked at medical records of about a 250,000 Americans. And it looked at those that had COVID and the chances of being diagnosed with either a behavioral health issue or any type of like, let me see exactly how they classified it. They looked at any psychiatric disorder, right? So they looked at 2 months out and then they went back and looked 6 months out. And they found that a little over a third of people who had COVID ended up with a diagnosis of some sort of psychiatric issue. So anxiety, I think anxiety and depression were the biggest two. 17% ended up with a diagnosis for an anxiety disorder, 14% other mood disorder. So one of the questions would be like, okay, but that occurred within the context of this whole pandemic and stress and all those types of things. Maybe that's just because of the stress of the pandemic and it never, feeling like it's going on forever, right? So super cool. Compare that to people who had either a diagnosis for the flu or who had a diagnosis for some other non-COVID respiratory infection, and it was actually higher. So it does appear that there is likely, still it could be the stress of having, but it does seem like there is a mental health impact of COVID long and people really suffering beyond just the physical, with which obviously Denise shared all the depressing stuff about that. When they looked at people who had the really extreme versions, so the people who they operationally define that as people who were in the ICU, and they looked at neuropsych tests, they did see for the folks who had that really extreme COVID experience, ended up in the ICU, that they did neuropsych testing along the way and found that they had an impediment similar to a moderate TBI. So we're struggling with things like memory, attention, executive functioning. And executive functioning is everything from like operating in daily life, managing your own finances, those types of things. So there does seem to be an impact, a psychological impact long-term and an impairment in cognitive functioning. So then you also look at it, obviously, from the endothelial dysfunction, looking at when they looked post-mortem at brains, they saw higher rates of inflammation and then also leaks in blood vessels when they looked, when they looked at the impact post-mortem on the brain. So there's that side of it. And then also just the stress. And a lot of departments are seeing struggles with this. We have talked to a lot of departments and their behavioral health teams or their peer teams. And a lot of them are saying that they're starting to see just really an uptick in the days, the longer this goes, the more stress. Another thing that I would bring specific attention to beyond the stress of the members is that we're really hearing from those peer health folks, especially the ones who have great peer teams set up, that we're starting to see the peer members just burn out. Like they volunteered for the positions, obviously, to, serve their colleagues and be a support. And we're starting to hear from those folks, especially those that have really active peer teams, that the peer teams are kind of at their wits' end. And often it's funny because at the end of one of the webinars, someone asked, what are each of you, being leaders of peer teams and psychologists working with departments, doing to take care of yourself? And the look on everyone's face was, so while it's really, I think in general, that's something that the fire service needs to be talking about. And I think the behavioral health, the folks who are really responding to that should be focused on is that I think they do a great job, like with the firefighters in general, they do a great job taking care of other people, but less of a good job taking care of themselves. And I think at this point in the process, we're seeing that even more, where there's behavioral health, peer support folks need some relief on their own and some taking care of each other too and themselves.
Sarah, well said. I mean, obviously there's so many of these physical components, and Denise, your explanation of everything from the scientific perspective is very helpful. But I think I am more of a sociologist and psychologist, and just thinking of the social impact and the wear and tear, and especially just thinking about all these other existing stressors that we have in the fire service, and having to work overtime and just constantly having to put yourself on the line. I think we need, and this brings in the whole conversation of additional mental health resources and different things that we can make available. So what might be helpful too is if, and I see Lori, if you wanted to now parlay into that, of giving some recommendations of any resources on that firefighters or fire service can take from not only the physical component, but some of the mental component, because I know that's the other battle that we're facing here.
Absolutely. And I'll defer to Sarah, in regard to resources, but what I want to make a delineation in is that there is, we may think that, well, let me say it another way. There are definitely behavioral health implications for just the overall lockdown this year, right? The overall, COVID pandemic experience that we've all gone through, whether it's with our families, at work, the extra stress of the exposure, all of these things that we're thinking through. That's one piece. But the other piece that I think Sarah referenced is that there may be distinct lines from COVID, having had COVID virus, to a behavioral health situation or a long-term ramification. So we're talking about long haulers here. And this is sort of the point I wanted to make, is that, yeah, we're all probably depressed and got long-term, behavioral health issues that are going to be coming out of this lockdown, right? But the other thing is that there can be a physical connection that leads to behavioral health exhibits of symptoms and situations. So Sarah, am I saying that maybe not as succinctly as you would have said it?
No, I actually think you said more succinctly what I said. So I think that was fantastic. Yeah, but both arms of it.
So Kevin, shall we talk about exposures?
If you could give us some context on exposure tracking and presumption, please, that would be awesome.
Absolutely. So I am gonna, just because sometimes presumption, for those who are not particularly familiar with the details, it gets a little crazy. So I do have a couple of slides, if that's all right, that I will share. And unlike Denise, who was so effective in getting you her slides early, I wasn't as good at that. So I will just share mine. So is everybody seeing them? Yeah, okay, good, perfect. So I'm talking a little bit more about just presumption. So immediately, almost the federal government here in the US, and I know we've got multiple nations on the line here, so that's fabulous. But here in the US, there was a presumption issued so that those on the front lines, primarily for first responders and healthcare workers, that it would be presumed that it came from the job should you have COVID and experience any kind of disability or long-term impact or death, that it would be assumed. But let me tell you a little bit more about presumption, and then we'll talk more about what the COVID presumptions are in place right now. So presumption itself really is this link between some sort of an occupation or a condition to some hazard associated with that occupation. And so COVID certainly put us into that realm. That was an additional hazard that was put on first responders in particular, and all of our healthcare professionals, but we're kind of focused on our little niche here of first responders. And so their exposure, and should they contract or have any long-term impact from this disease, it would be presumed to be from that occupational exposure. And so generally that link or a presumed link is enough, but it can be that someone can challenge that. And we see that a lot more on the cancer side right now than we've seen with COVID. but it's not to say that it couldn't be longer term, because we see these long haul effects. What's to say that there won't be some disability associated with it that you want to claim presumption because it was connected to COVID, contracted off the job, right? Making all those links may be a hurdle going forward. And so it is important that we understand that just because it's a presumption today, that burden of proof, if it's rebutted, the burden of proof can shift from being on the job to say you didn't get it from us to you having to say, yes, I did, right? And having proof of that. And so it's important that we all understand that often there can be a requirement for exposure proof, right? If there is a challenge to a presumption, okay? It doesn't happen at the first line when you file a claim. It happens if there's a rebuttal to that claim. And so we see it, as I said, a lot on the cancer side, where we've got almost every state in the US, 48 states actually, have some sort of cancer presumption. All of Canada has cancer presumption, every province. And so these presumptions, again, the link is assumed. But what a lot of us don't understand is that in that presumption law, there is nearly always a requirement for evidence of exposure. In other words, you've got to at least say that you were on a call. You have to have evidence that you actually made a fire, right? You actually were on that call. And so you can see here just the rebuttals that can take place, and they can come from different areas. So from your insurance company, whoever's handling workers' comp, it can be from the employer itself. And for those who are retired, sometime during this thing, and we've seen a lot of retirements during COVID, right? And so if you're retired, you had COVID on the job, you retire, and now you've got long-term impact, right? Making those links back are going to be extremely difficult. And so we really have to understand what is happening with our presumption. So this level of proof, it has two different levels. One can, your state or province could require a preponderance of the evidence, and that's more of like a 50 percentile, right? Or clear and convincing, which moves that needle over to being more like a 95 percentile if the claim is rebutted. And this is going to vary by states and state laws, particularly here in the US. So what does that level of proof mean? And so I here's some more detailed definition, so you'll have it, for the recording going forward. But again, it's more of a 50 percentile, that preponderance of evidence versus clear and convincing. And you know this from the legal system anyway. So these are terms that you're probably familiar with. And so just the last sentence there, that if a claim is rebutted, the firefighters' counter arguments become much more difficult. And so in that proof, then we would have to show at least these three items: that you have the illness, talking about COVID-19, that you encountered it while working, and that there was some sort of link, between the two. Your occupation caused you to be in the place where you contracted this virus. And so having that presumption in place matters, but it can be rebutted longer term. So here is what Congress has passed so far, and this is really, really good, but I wanted just to kind of point out some of the details. And this is Safeguarding America's First Responder Act that was passed. And so it does extend our PSOB benefits for both death and disability to include COVID-19. And so those death benefits are certainly covered in a general presumption, as are the disability benefits covered in that general presumption. But what I want you to look at is the very last statement, the last bullet down there. So it was established as a statutory presumption for law enforcement and other first responders who die or disabled from COVID-19 complications, right? Or as they sustained a personal injury in the line of duty. That's important, provided that they engaged in line of duty actions in that time frame. So in other words, you're going to have to show us that you made a call, that you were on a response where there was a COVID patient, or you came in contact where you could have contracted COVID. So just because we say it's presumption and it's assumed you got it on the job, there is still a data link here, right? That you show it was a personal injury in the line of duty where you engaged in a line of duty action in that time frame. This is where we get lost a lot of times, is in the detail. So we can't just say it's an outright presumption because there is evidence of contact or evidence of exposure that is required. And so I want to tell you about some state actions too. That's a great bill that was passed and it's good, but you've got to, again, make sure you've got your evidence together should you need it for that presumption. But there are some state actions that are happening too. We've got a total of 17 states that have taken some action on workers' comp. You've got another 9 that are creating some, presumptive laws themselves. You also have these 3 states that I've listed, Minnesota, Utah, Wisconsin, who limit it to first responders and healthcare. So the presumption is not a general presumption. It's limited to these groups. We've then got some other states who are calling it all essential workers. So that's going to get into, some of your public service groups, your garbage folks, your janitors, things, that go beyond the first response and healthcare. And then there are at least 4 states, and there are more who are in progress and doing some sort of executive order for these presumption policies for first responders. So let me show you the map. This is a map that the IFF actually is using right now to track all of these different legislative efforts in regard to COVID presumption. So you can take a look at your states here and see where we've got some executive order protections in place that we just referenced. You've got some general disease, legislation going on. We've got some state labor directives that are happening. And so COVID, it is recognized that COVID is going to be a long haul or a long-term scenario for us, right? So understanding what's happening in your state, understanding what is taking place with the legislative efforts for coverage, but also making sure that first responders have their own exposures documented, right? Or the days you worked on the job, the calls you made, whether they were a COVID call or not, what days in some sort of career diary that when you were on the job, because again, you just saw the criteria that are going to be caused in those in the legislative, whether it's at federal or state. In every state, just like we see in the cancer presumption, every state presumption is going to have an exposure report requirement. You're going to have to show some sort of evidence of exposure. And so that's where it brings me to what we are doing at the Institute, and I hope everybody on this call has heard of the N4's exposure tracker, funded by Homeland Security Assistance to Firefighters grant. It is free. It is in both app stores. You can download it. If you haven't already started your career diary, please do so. We added COVID tracking to this last March, so it's been in there over a year. We immediately made the shift and put it in the EMS module inside the exposure tracker. We've also beefed up the PPE documentation. So you'll be able to actually document what PPE you were wearing on the job, all of those kinds of every single call, and yet be able to show that you still contracted COVID perhaps, right? Even though you were being as careful as possible. And so it's important that you have this documentation. So this is a way to do that. It does have the 5 modules, one for cancer or fire, obviously, exposure to carcinogens, EMS, hazmat, tech rescue, and Sarah's favorite, the behavioral health module, and where we can document still those traumatic events. And so even these kinds of exposures where you may have, dealt with a COVID patient and you are struggling, dealing with that even mentally, documenting that in that behavioral health module as well, so that we have this documentation should you need it. It's secure, it's encrypted, it's private. The department cannot see what you document. This is your information that you maintain for life in your own device, in your own app. So with that, I'm going to unshare, Kevin, and go back to the discussion.
Fantastic. Thank you for that. And yeah, if you're a first responder and you haven't started using N4s, that's step 1. Make sure you check that out. And we're 2 minutes past the hour. I think we'll end up going for another at least 10 to 15 minutes. So I apologize, but this is now kind of where I want to get in some of the open Q&A. But there was one question in the audience there, and I think it was answered, or Sarah, you answered it But I think with looking at those that have contracted COVID and are trying to overcome the challenges of COVID, there's obviously many dynamics there. Sarah, I saw you responded, but if Stefan, thank you for the question, but Stefan contracted COVID and is still struggling with tiredness, brain fog, lightheadedness, and struggling to kind of get back to physical shape. But Sarah, you want to just give a quick little context on that, and then as well, Denise, Todd, Lori, and any context on firefighters and how to overcome and get back to their best self.
Yeah, I just shared an article that I'd come across on that question, but I think I would defer to Denise on actually most questions in life. I defer to Denise, but this one in particular.
That's what I always do.
Denise, you're on mute. 2020 things.
The problem was not exactly that I was on mute, it's that I don't know what to say. And I think it's one of the real challenges that, a lot of the question was about, how much exercise can I go back and safely do? I don't think that question has been answered. Sarah, I'd love to see the article you sent, but I don't think we know. I think we're concerned because we don't yet understand all of the mechanism, and we don't know who is vulnerable and who isn't. So whereas 95% of the people may be able to set up a moderate exercise regime and go back, 4% that might be horrible for, and 1% it could be catastrophic for. And I don't think we have the risk stratification down very well at all. But it does bring me to concern. I think that there is something that is self-limiting and protective in most of the population. I talk to the fire service most of the time, but I've got some friends who aren't in the fire service. And when I talk to them, they will tell me things like, oh, my physician told me it could be 2 or 3 months before my lungs really return to normal. But those people are kind of going slow at life naturally. Firefighters come back to work and go to exercise, or, maybe they're not doing too much around the station for the first 4 or 5 days. But the question in my mind, and we don't have research as far as I know, what happens if they catch a fire? Because now you're going from, oh, I was fatigued, oh, I was just dealing with that, everything was okay as long as I didn't do too much, to, well, everyone on this call knows what you can do if you catch a big fire. So I'm concerned about it, and I don't have answers. Sorry.
That's a great point, Denise, too. And for the chiefs that are on, obviously our occupation is a lot different in the rigors, from most any other. And while we don't have, to me, that is an alarm bell when I hear Denise saying we don't have the answers. So we certainly don't want to rush our people back through recovery and through their process. And we need to be thinking about how to accommodate them. Lori did a great job. We're fortunate that a lot of the presumptions are being put in place. But organizationally, until we know those answers, we have to go slow, I think, very slow from an operational standpoint.
Thanks, Todd. Lori, I wasn't sure if you had anything else there, but I see, sorry, before I go on something else, Lori, any other comments there?
No, I just concur with what both of them said. We're learning as we go here, and we keep hearing, and Sarah may weigh in on this, but we keep hearing about, we may get a vaccine booster, right? And people are like, this vaccine is going to last a year, 2 years. Well, we don't know yet because we're not there, right? We've only been vaccinated now for about 6 months, and we still have a lot to learn. So I think this is the case here as well, is that we don't know yet, but we do need you to be alert to your symptoms. We do need you to be alert to other symptoms. We need to be watching each other and think, this might be COVID related. Just have the thought. And I think that's what we're all trying to encourage here today.
Thanks, Lori. So we're 6 minutes past, but I wanted to maybe sort of give this as a last chance to give a challenge or a question to everyone that is listening, or listening now or listening later. where it's April 16th, 2021. We're maybe seeing light in the tunnel and vaccines are going out, but we're also seeing cases go like crazy. And we're now just experiencing and learning more about this long hauler effect. And as well as Todd, you gave context about the tragic events at 9/11 almost 20 years ago. We're still unpacking the risk and challenges and the impacts to this, especially the fire service. So give us sort of a final, I always call it just like a little bit of mic drop, but a final call to action, question, challenge to the audience about this conversation from your perspective. So it's sort of putting you on the spot, but feel free, whoever wants to go first. Denise, I see you're off mute, so I can put you on the spot, I know. So any thoughts on that kind of final thoughts, call to action, challenge for all of us today, Denise?
Yeah, I will, and I hope you'll permit me to speak freely to people I care desperately about in terms of firefighter health and safety. I suspect that the people on this call really care about COVID and understand a lot of the risks. But there are evidence that a good number of people in the fire service are hesitant about getting a vaccine. And I want to say I can understand that because someone just mentioned 9/11. I think it was Chief LeDuc. At one point, we heard that pile was not unsafe. You could be there without respiratory protection, and reasonable people could have acted upon that advice. I'm not going to say anything about people who did that. I have nothing but respect and admiration for them. But we know medically now that that was wrong and there's terrible long-term consequences. So I guess if I have a minute to say one more thing, I would say I hope we all use whatever influence we have to ask people to reconsider in the light of all the evidence we now have, whether or not they would get a vaccine. Because early on, we heard some intimation that the disease wasn't that bad, that people just recover, kind of like the flu, we need herd immunity. All of those things had grains of truth and reasonableness in them, and reasonable people could have thought that. We know more now. One, about the safety of vaccines, and two, about the long-term consequences, and that it can happen even to people who have mild cases of disease. And so I am talking to people that I care deeply about, and I would extend it to the people on this call. It's time for people with vaccine hesitancy to take a fresh look and consider the evidence. And I hope more people will get vaccinated and that we will keep the fire service safer.
Well said. Lori?
So I will just say, as my mic drop, please track your exposures. Whether you use the Enforce mobile app or our web-based version or some other version, even some sort of written diary, please track your exposures to everything on the job. And there was a question in the Q&A about how do I get resources to sort of push this in my department. Please reach out to us. Go to the website. You can contact us. I will send you station posters. We'll send you backup. We'll send you tips for working with labor management. Anything that we can do to support that effort within your department, globally, we will do that. And so we stand by with those sorts of resources. So please, and I'll put it in the chat, the website address, just in case you don't have it. Okay.
Thanks, Lori. Sarah or Todd, final thought. Sarah?
I would, I loved what both Denise and Lori said, as always, but I do think there has been so much conversation around, and that's part of what's created a lot of the confusion around COVID and vaccines. And I think that the science on this is not confusing. So I would say follow the science on this and try to mute the rest of it. The science on this is actually pretty clear, especially when it comes to vaccines. With the new variants that we're seeing, there's not going to be a way to socially engineer or herd immunity or way through that without vaccines and heavy vaccine adoption. So Denise is right on. It's the time to reevaluate that. And I get it. I get the confusion. I get the concern, but we've got great data for those that have said, I'm waiting. to hear and see how it all plays out. It is played out. It is played out. We know what that's looking like, and it's amazingly scientifically, medically, like the most amazing advance that we'll probably see in our lifetime. So now's the time to jump on board. And then I think my only other, if I could have two, I was actually holding two mics, so that's one. The other mic is take care of yourself, take care of each other, take care of the people that are taking care of you, because I think this is so long, and it's like everyone's exhausted. Everyone is exhausted, but this is the time that we all need to kind of like look inward and say, what do I need, and how am I going to get myself there? Because we've got to take care of ourselves before we can take care of other people.
Boom. Love that. And Todd, want to round us out here?
Yeah, absolutely. I echo all the wisdom and guidance from my colleagues. What I wrote down in my chicken scratch here, four takeaways that I heard today that are tip of the spear, actionable, that we can put into place as the research and science continues to evolve. And obviously, I'm not going to touch on vaccines because I think each of us have made clear how important vaccine deployment is. But help us, we've recorded this today. So help us increase the awareness within your agencies and within the fire service. That's so important that we continue this dialogue as we learn more and follow the science. Make sure your department has behavioral health resources identified and available to your members. And there's a ton of resources out there, IFF, IFC, National Volunteer Fire Council. Make sure your department has a robust firefighter physical in place. I know one of the attendees said it's a challenge to fund those. Assistance to firefighter grants are a great opportunity to provide that resource to your members. And lastly, as Lori did a great job explaining how much progress we've made with presumption with regards to COVID, in larger issue, other occupational diseases, that exposure tracking. I know sometimes it can be tedious to track your exposures and your calls, but it's so important when it impacts you and your family. And that's something that the resources are there. They're turnkey. Lori's group can help you just dial them right up. And we need to just make that a cultural habit that we all do, and as leaders that we support. So 4 quick takeaways. I'm sure there's many more that will evolve, but those are actionable that you can put into place, today going forward. So want to thank, I think if I had my math right, and math wasn't always my highest suit in school, I counted 4 countries. And I hope I didn't miss any. US, Mexico, our friends to the north, in Canada, and I think Sweden was on too. So obviously this is not just a United States issue. So we'll continue to learn from each other's experience. And I want to really say how honored I am that we had such tremendous conversation today, and such great talent that is focusing their effort, amongst other work, on helping us better understand this for fire service leadership.
Yeah. Wow. Well, thank you all. I've got solid 2 pages of chicken scratch myself for some recap, and we'll be doing some short form repost of all this. And this is just tip of the spear of the conversation. We need to get the word out. We need to continue to collaborate and get it out and be a team together. So we'll have more of these roundtables. We'll have more of these podcasts. If you're on Clubhouse, this new sort of talk house, live radio meets town hall app, I need to get all of you, Lori, Sarah, Denise, and Todd, on there. Audio only. We're doing more events on there, and that's even more casual. Get it up, get it out there. So be on the lookout for that. Make sure to, I'll take all your emails and send an email response, but we'll continue to host events, bringing value to you and move the needle here together as a team. So I want to thank you all for giving us some of your time today. And for those recording, nice to hear. Thank you for listening, and hope you all have a great Friday, great weekend ahead, and much love, and stay safe.